because of this broad neural network, a stroke in many, many different areas could potentially lead to dysphagia. Often when I think about which areas are involved, it's probably easier to say which areas are not involved.
Hello and welcome to a new episode of Dysphagia Matters. In this episode, Janina Wilmskoetter takes us on a journey into the depth of the brain to help us understand the potential impact of stroke on swallowing. Why does a stroke cause dysphagia in some people and not in others? And why do some recover more quickly than others? And does the location or the size of the lesion matter at all? We had lots of questions for Janina, and we were really delighted that she joined us to share both her research findings on stroke and her clinical expertise as an SLT. Enjoy listening.
Hi Janina, welcome to our podcast. We are very excited to have you as our guest today. We are really looking forward to recording with you about your research. It's so interesting. But before we dive into the topic, would you mind introducing yourself?
Of course. So first of all, thank you so much for having me. It's an honor to be on your podcast. So my name is Janina Wilmskoetter, and I am currently an assistant professor at the Medical University of South Carolina. So it's at the East Coast of the US. I always say it's between New York and Miami. And I am in the Division of Speech-Language Pathology. And we just opened 2 years ago, a master program in speech-language pathology. So I'm teaching there and I work in the hospital as a speech-language pathologist. So I work on the acute care. I also work in the ALS interdisciplinary clinic that we have and in an aphasia clinic. And then I also do research, mostly in stroke. And I think that's what we are talking about today. So in stroke recovery for dysphagia and aphasia.
Yes, exactly. So our topic today is post-stroke dysphagia, and you're really an expert in this field. So we know that strokes occur more likely in older than younger adults. So maybe before we talk about strokes, let's start talking about brains in older people. So what is the state of the brain in older people?
Yeah, so that's a really interesting question. And especially also relating it to swallowing, there's not much known how we can relate it specifically to swallowing and aging effects, but there's a lot of research to aging effects on the brain in general. And of course, that's because our population in the world is aging rapidly. So we are really interested in understanding what's happening. And so some of the most common age-related changes in the brain are for example, brain atrophy. So what is basically an increase in cerebrospinal fluid in the brain and counterbalanced by a decrease in gray matter volume. So basically a decrease in the core brain tissue, and not only gray matter, but also a decrease in the white matter. So we lose some of the brain structure while we age, and that's giving us less structure to work with. So atrophy is one thing that we commonly see, and that's a normal process. But of course, the degree to which some people might experience atrophy can be variable across individuals. So some might experience more atrophy with aging, some experience less atrophy with aging. And some other occurrences that we see with aging is something called small vessel brain disease that is very, very common with aging. So I think up to 90% of older people later on after the age of 80 present with some degree of small vessel brain disease. But again, the interesting part is why some people might experience more and some people experience less of these aging effects. And the cerebral small vessel brain disease can be evidenced by atrophy of the brain, but also something called white matter hyperintensities. So when we would do a brain MRI, there are some of these hyperintensities in the white matter, so where the axons are from the brain, or little hemorrhages, so microhemorrhages, or really small infarcts. And this is typically subclinical. So we would not even know that someone has those structural changes in the brain until you might get an MRI for something else. But what's interesting is that all these structural changes can be related to some like very subtle changes. So for example, we know that a mild cognitive impairment is related to these like small vessel brain disease changes. Or when we look more deeper and apply more detailed measures, then we can find relationships to maybe lower motor performance in older age or more falls in older age. So there are some of these like typical structural age-related changes that happen with older age, and that can be related to cognitive changes and also to motor changes. And now more recently, we've also tried to explore like how this relates to swallowing. And interestingly enough, we think it does, so that there's some relationships to that as well. But I think what we all try to understand better is why there's such a variety. So some individuals might experience a lot of these age-related structural changes in the brain and others don't. And that's, I think, where science needs to progress or needs to find a lot of answers so that we can maybe prevent or slow down those aging effects in the brain.
Yeah, that's really interesting. And oftentimes we just talk about changes related to aging, but of course it's the aging, but it's the underlying structure that is changing or the system, and it's just occurring with the age, but it's not actually just aging.
That is so true. Yes, age is just a number, right?
Yeah,
so we often say this, and sometimes I feel like we say it to make us feel better or something when we get older. But like, since I like dove more into this literature, age is just a proxy. It's just a surrogate for something that happens in the body, exactly as you said, right? So it's like there are so many underlying processes going on in the entire system of the body, right? And brain is just one of them, but we also experience changes in our respiratory system and our metabolic system, right? And those can be very different from person to person. I think that's where it also becomes so interesting to think about like who's recovering and who isn't recovering, because we are all coming in with like different set of structural predispositions or a different set of cognitive predispositions.
Yeah, before we talk a little bit more about this specific part, let's discuss what regions of the brain are usually involved in swallowing if we look at healthy brains in people maybe younger and older.
Yeah, so that's a great question. And I wish I could say like, oh, we exactly know this, which areas are involved, but big surprise. I think that's like the most common answer in like dysphagia research. We still try to understand. You probably all know that originally, like decades ago, we thought it's just quotes the brainstem that is involved, right? And that of course made a lot of sense, because in the brainstem there are the cranial nerve nuclei, and the cranial nerves are of course very obviously involved in swallowing control. And so it made sense that lots of research and attention has been brought to the brainstem, and especially because swallowing is a highly automated process, right? So there is a lot of brainstem or subcortical structures involved. I think what was really also interesting from the stroke literature is to understand that people can experience swallowing difficulties even if the brainstem is completely spared of any injury. So then we later understood, oh, it can also happen if just the cortex is involved in the lesion. So from this type of literature, and then of course even more like fascinating literature with like neurostimulation or like fMRI or EEG data, we now have a better understanding that actually really broad neural network, bilateral neural network spanning from the cortex to the subcortex, and then of course the cerebellum and the brainstem are involved. So often when I think about like which areas are involved, it's probably easier to say which areas are not involved. So, and I think this gives us a lot of leverage to also really argue why it's so important to assess patients no matter where their lesions are. And I think we will touch base on that later again. But so when we just like start from the brainstem, so of course the medulla, where we have the ventral and also the dorsal swallowing group, and then we go up to the pons and to the midbrain, where then more cranial nerve nuclei are located, and then we have the corticobulbar tract going through these structures, going up into the cortex. So we have, of course, the primary motor cortex, and I think that's what I would say like the most commonly investigated area. So motor cortex, then the corticobulbar tract going down into the brainstem. However, that's just maybe the core of the swallow network, but there are other areas involved that help in coordinating the signals sent to the brainstem. And those are then the premotor areas, the supplementary motor area, and then, of course, a lot of sensory processing as well. And I think sometimes we tend to forget about the sensory parts because we strive to talk about the corticobulbar tract. So then, of course, it's like the thalamus as well. So lots of like basal ganglia areas that have been involved in swallowing, and then the cerebellum that has been involved in swallowing control. Then it becomes a little bit more raising more questions about when we think about also temporal areas or the supramarginal area, angular gyrus have been associated with swallowing control. These are then, of course, a little bit more interesting because we do not understand the exact role in each and every of those regions and areas. Yeah, so it's a broad neural network spanning from the cortex to the subcortex and then down into the cerebellum and brainstem.
Yeah, thanks so much for that overview. And so I think it's really important, like you said, it's not all about motor movements. It's about the sensory system as well and about the coordination of all of it. So it's, yeah, as we all know, swallowing is pretty complex. Now going back to the aging effects and to stroke, what is known currently about aging effects on the brain in people pre-stroke that later on develop a stroke and that might then impact dysphagia or swallowing in general?
So yeah, that's a great question. And so what has been done in the past is, of course, we started with just looking at the physiology of swallowing, and I get back to the brain changes. But so there has been a lot of research trying to understand what changes occur with swallowing just when we age, in absolutely absence of any other diseases. There has been studies to better understand presbyphagia, right? So age-related swallowing decline. And we see things like more airway invasion of a bolus, so more events of penetration, aspiration, more events of like residue, et cetera, So this, of course, gave rise to also the question, well, is there a neuroanatomical correlate to that? Or is that just pure peripheral decline in terms of sensory processing or in terms of like motor movement, or just is it because of peripheral muscle loss, etc.? Some interesting studies were conducted using, for example, fMRI or EEG that found that there's also an increase in cortical activity in older individuals compared to younger individuals. And I remember when I first read those studies, I was surprised by it because I was like, wait, an increase, so more activity? That sounds great, doesn't it? The thought or the interpretation of that was that the authors thought, well, that might be actually a compensatory attempt of the brain to try to adjust for those peripheral decline that we see in the oropharyngeal musculature. If individuals, when they age, might not have such strong sensory processing skills or might lack some of the coordination, might have less muscle to work with, the brain needs to work harder to achieve still a functional swallow. Because while there's a decline in swallow function, typically an older individual still swallows quite well, right? So they still can eat typically their normal diet. They don't need to have like specific diet adjustments. They typically not have lots of pneumonia. So the swallow still works, but it seems like the brain just needs to work a little harder.
You say the brain needs to work harder. It sounds like they have to concentrate more and put in more effort. Does this mean that, for example, if older people do dual tasks while eating and drinking, for example, they have lots of stimuli or are watching TV or trying to interact in a conversation, that this might interfere with swallowing?
Yes, I think that's a very, very good thought. So maybe this is the next study someone should do, whoever is listening to this podcast. But yeah, so these are definitely things that we should all think about, and also in conjunction with, I think, the cognitive decline that we see with aging, that has also been related to swallowing tasks with aging. So I think aging does not just affect swallowing, right? So aging is something, what you mentioned before, that affects like all body systems to different degrees. So cognition is one, swallowing is one. And then of course also like things like being distracted or trying to focus, or respiratory coordination, what is very, very important with swallowing, and eating as well, is also might be more challenging with aging. So I think these are all great things to think about. How can older individuals adjust their eating habits or patterns to still maintain a maximum safety and efficiency, and of course enjoyment of eating and drinking, because that's all about it, right? That we all want to enjoy eating and drinking.
Yeah, absolutely. If we consider all those aging effects on the brain now in a healthy older person, how does this might differentiate then an older person from a younger person who has a stroke and might develop dysphagia?
What we think currently is that aging effects on the brain predispose an individual to have higher risk or higher likelihood for decompensation after an injury and an additional injury to the brain occurs. Before a patient has a stroke or another injury to the brain, the swallowing control seems to work just fine, but with a lower resilience and with a lower overall capacity. Because now with an older individual, we have like atrophy of the muscles. The brain tries to compensate by engaging more areas in the brain to control, to achieve the same result of swallowing. So, and now when we have a sudden injury to the brain does not have as much reserve to compensate for that injury as maybe a younger person has. And a like more concrete example is when we think about the small vessel brain disease that includes white matter hyperintensities. Those white matter hyperintensities were present already before the stroke. And those white matter hyperintensities very, very often actually affect the corticobulbar tract. So they are in the areas where those corticobulbar tracts, corticospinal tract, etc., so where these typical motor tracts are. And these white matter hyperintensities, they might just like diminish the function of those tracts just by a little bit. But if we now add a stroke, so an acute injury, this individual does not have as much reserve to compensate with the brain structure available as someone who has an entirely healthy, young, intact brain. This is one reason why we likely see more and more severe swallowing impairments in older stroke individuals than in younger stroke individuals, because of the lower reserve they bring when they have the stroke. I hope that makes sense.
Yes, absolutely. So the size of the lesion, the site of the lesion, or everything could be the same in a younger and an older person, but the older person actually might develop dysphagia and the younger person might not.
Exactly. And that's something that we are really still trying to figure out, right? What exactly are the mechanisms? Because as you said, age is just the number, right? But what exact neuroanatomical mechanisms that are related to age can explain this variability? I try to always think about it as if someone has to undergo surgery to resect one kidney, for example. That's more or less common surgery. Of course, doctors will assess the remaining kidney in terms of the health, right? So someone who has a healthy kidney will have better outcomes after resecting the other kidney than someone who has not an as healthy kidney. So if we now think about a stroke that occurs to a brain that is healthy otherwise, compared to a stroke to the brain that is not as healthy, well, that makes sense why these two individuals probably have different outcomes, because part of the recovery process that we see with swallowing depends on the residual brain areas. And with residual brain areas, I mean the areas that are not affected by the stroke, right? So we have the brain areas that are lesioned and that we need to take out of the equation, at least if they are not reperfused or if they are not recovering. And then what happens with the neuroplasticity during swallowing recovery is that the residual brain areas, so those that are not affected by the stroke, try to compensate for what was lost by the stroke. And if those areas are healthy and have a lot of structure and have a lot of like neurons, connections, they are probably more likely to be able to compensate for the stroke than if those areas, the residual brain areas, are less healthy in terms of like what neurons do we have, what glial cells do we have, are there already little microhemorrhages in these areas, are these areas maybe prone to white matter hyperintensities?
Yeah, so I think you answered our next question due to your great explanations. So the question was, why is dysphagia so common in people post-stroke? And I'm going to try to answer it, and you tell me if it's right or wrong. So based on what we know, strokes occur more often in older people. And we know that the brain changes the older people get due to all the factors that you've listed. So it makes sense that the reserve is becoming smaller and smaller, the swallowing reserve. They can't compensate that well anymore. So if they have a stroke, it is more likely that this whole system collapses and that they can't compensate for the swallowing difficulties. And this might be why there are so many people with dysphagia post-stroke.
Yeah, you summarized that way better than I could ever do. Yes. You described it so well, like what we need to like take into account when with older compared to younger individuals. And of course, it's like one big factor why dysphagia is so common after stroke. And when we say so common, it's like the most common functional deficit after stroke. It's more common than upper extremity impairments and walking impairments than anything else. It's because I always think about like these two major reasons. So one major reason is because swallowing is so complex. So just the swallowing process only takes 1 to 2 seconds. More than 30 muscles are involved that need to be coordinated at the exact right time. At least 5 cranial nerves, we are thinking of controlling this movement. And so it's very easy that one little disruption results into throwing this process off, right? So first, the process itself is so complex, so it's so easy to be disrupted, unfortunately. And then thinking in terms more of stroke, because of this broad neural network that we just talked about, a stroke in many different areas could potentially lead to dysphagia. And that's different when comparing it to other functions after stroke. So for example, I also researched aphasia after stroke, and the neural network that's involved in language is a little bit more focused to a specific area in the brain, right? So typically in most individuals, right-handed individuals, it's more the left, temporal, frontal, parietal areas. But with swallowing, it can be that a stroke in the brainstem, and stroke in the cerebellum, a stroke in the basal ganglia, in the thalamus, in the frontal lobe, in the temporal lobe, in the parietal lobe could potentially lead to dysphagia. So this already is like some of the reasons why dysphagia is so common, but then adding those aging effects that we talked about, it's even more common than in older individuals than in younger individuals.
Okay, we'll move on to a paper that you published in 2020. It's the title is Cortical and Subcortical Control of Swallowing. Can we use information from lesion locations to improve diagnosis and treatment for patients with stroke? You wrote this paper together with your colleagues Stephanie Daniels and Arthur Miller, and we have a few questions about this paper. First of all, you raised the question why many but not all patients with stroke recover from dysphagia. What is known about this so far?
So this is a great question. Again, I wish I could say, oh, we know this so well. But I think that's why we are all here, that we still try to find answers, and we all need to keep doing research, if it's with our patients in the clinic or if it's doing in a scientific, systematic way. interestingly enough, when we think about swallowing, while there are so many patients who have swallowing disorders right after stroke, there are also a lot of patients who recover within the first days or even within the first week, just spontaneously. So I work as a speech language pathologist in acute care with acute stroke patients. And I always think, oh, I can like pat on my back. That's like, this is great. The patient recovered. And it's probably because of me. No, of course not. I think one thing that swallowing has that makes a lot of sense is that it's also redundantly organized in the brain. And when we think about swallowing is a vital function. Without swallowing, humans wouldn't survive. Except, of course, if we would think, yes, they are feeding tubes, but just like from a very biological point of view, we need swallowing to survive. So it's a vital function. So it does make sense why our body has implemented some redundancy to swallowing control, to swallowing, meaning that the swallowing network can recover quite well to restore swallowing function, because it's not that just like one area is responsible for this one function, and if this area is knocked out, then swallowing control cannot like kick in anymore. We cannot swallow anymore. I think there are, of course, like many different studies, but some studies say that up to 50% of those stroke patients who have dysphagia just recover fine within the first week. So, and that's fantastic, right? So while maybe at the beginning we need to bridge the time with some precautions, most of our patients that we see initially with dysphagia recover within the first week or first weeks, and likely because of this redundant representation of swallowing in the neural network. However, then there are these other 50 or whatever percentage of patients who do not recover. And that's, of course, more important to us as health professionals to understand who are those patients, because they will need our treatment or our management. And it's important for us early on to try to predict who is the patient who is not recovering, because, of course, this will then maybe bring up discussions on like alternative means of nutrition. Do they need like early rehabilitation or not, etc. One thought process in swallowing research has been that the unaffected hemisphere could compensate for what has been damaged in the affected hemisphere. And of course, this like theory makes sense for patients who have a unilateral stroke. So the idea has been that, okay, if a patient, for example, has a stroke to the left hemisphere, then the right hemisphere could potentially compensate for what was lost in the left hemisphere. And the neurobiological underpinnings to that, or reasoning, is that swallowing is a bilateral controlled movement, and it's a bilateral function. So some of the representation that we have in one hemisphere is also represented in the left hemisphere, so the other hemisphere could potentially compensate. While this seems to make sense, then there are still some patients where this like idea does not really work. And there has been a lot of research from Shaheen Hamdi and his group in Manchester, who also raised the question about, well, there seems to be more of a dominant hemisphere. So not both hemispheres seem to contribute in the same way to swallowing control. And then the idea was, okay, if the dominant hemisphere is lesioned, the non-dominant hemisphere might have a harder time to compensate. And so those patients with a lesion to the dominant hemisphere probably have more challenges or are less likely to recover than a patient with a lesion to the non-dominant hemisphere. The problem for us clinicians is then, well, how do we know if the stroke was in the dominant or non-dominant hemisphere? Well, and that's still something that we try to find out. So it doesn't seem to relate to handedness, what often is the answer with when we think about language recovery, right? So that doesn't seem to have a relationship there. So that means that we are still kind of in the position of, oh, we need to wait, right, to see, like, does this patient recover or not? But then there are some other factors that I think that have been more and more well researched that we can take into account as clinicians. So age is one that we talked about. but then also lots of pre-stroke factors that come into play. That the patient already had a prior stroke, right? So some patients might come and it was not their first stroke, so a prior stroke. And where was the prior stroke? Did this affect already part of the swallowing network or not? So some research has been published. If a patient had a prior stroke to the corticobulbar tract and now there's a new stroke, those patients unfortunately don't recover well. Then also the location of the stroke seemed to be a contributor to who's recovering and who isn't recovering. I think a lot of us might have experience with working with patients with brainstem strokes in the medulla. They unfortunately tend to have quite long-lasting, severe dysphagia, so they need a lot of
or even like aphasia, like
yes,
they can't swallow at all.
Exactly.
Yeah.
Exactly. But those are also patients who tend to be highly motivated to do treatment, right?
Yes.
Because they are often cognitively intact, and it's most often the only really pronounced impairment that they have. So
but it's oftentimes so severe.
yes, yeah, you're right. Not the only, but like this.
Yeah. No, I know what you mean.
They're major concerns at least. And so motivation is a big factor in who's recovering and who isn't. Then things like support system is a big factor as well. And then of course, like frailty before the stroke, right? Again, we talk about predispositional factors. And then, of course, treatment, right? Do they receive treatment or not? So how much treatment? So rehabilitation has been a big factor. And so there are a lot of different factors that contribute to who might recover and who doesn't recover. And I think we need to emphasize part of it is related to the stroke. So where was the stroke? How large was the stroke? Was it the second stroke, third stroke? Part is related to the neuroanatomical changes that happen with aging, but then there are also a lot of factors that are not related to the stroke that will contribute to who is recovering and who isn't recovering. And I think that's then where also we as clinicians need to jump in to try to hone on those factors. So try to motivate our patients, try to offer the therapy, try to offer them how they can also like practice without us being there, right? So to increase the intensity, the adherence to therapy, etc.
What about the effect of complications? I was just thinking back to when you said, well, it might have not been your work as an SLT that you actually rehabilitated the swallow, but maybe you prevented complications, so you did help the patient in the long run.
I totally agree. And of course, it might not be our role in the acute care to start with really intensive exercises, right? So often there are some barriers for us to implement early on intensive exercises. Some patients, yes, it works very well. But for most patients, as you said, the primary role for dysphagia management is likely to keep them safe and reduce the likelihood of complications like pneumonia, like malnutrition, dehydration, choking, right? So, and of course, these are very, very important things that will not only impact swallow recovery, but will impact stroke recovery in general, right? So keeping down infections, making sure that the patient gets best oral care as possible, especially when they might be NPO, so when they cannot eat and drink. Oral care is very, very important. It's always important, but especially for those patients. And then, of course, something like preventing non-use effects, right? So maybe a patient might not be safe for a diet, but maybe as SLPs, we can encourage to take a few sips of something that we think might be safe. And this is a big discussion, and you might have another podcast on that, what that could be. But trying to prevent non-use atrophy, non-use effects in early stages is very important, yes.
Based on the principle of neuroplasticity, use it or lose it, use it and improve it. Yeah,
yes,
absolutely.
Yes.
We actually do have an episode about this topic. If you're interested, check out episode 17, Oral Trials in Dysphagia Management, with Jacqueline Banfield. I wanted to go back to the topic of location of the stroke. What are the clinical implications for us as clinicians then? You've already talked about brainstem strokes Are there any other locations or other things that we have to keep in mind when we're treating patients with specific locations of the stroke?
Yeah, I think one of the most important things as speech language pathologists is to be aware that many different locations, as we already talked about, could lead to dysphagia. And that's, I think, important for us also in discussion with other health professions who are not as great experts as we are, because we have all like the education in school, et cetera, et cetera. So if, for example, discussions in the health professional teams come up like, hey, I don't think this patient can have dysphagia because they have just like this very, very small stroke to the cortex here. So I don't think we need to worry about that. Then I think we have now a lot of evidence that we can confidently say, oh, this patient is at risk for dysphagia because of this like broad neural network. So a lot of different locations could lead to dysphagia. So we should always be cautious when we have a patient on our list with a stroke to anywhere in the sensory motor system, right? Anywhere in the subcortical areas, anywhere in the brainstem, etc. And so that's one thing where I think the location is really, really important. But then also a little bit more in detail that we start to get now more research and evidence for us to build hypotheses based on the lesion location, what we might expect in terms of swallow physiological impairments. I think everybody who works with patients with brain injuries, we kind of like already build our hypotheses of like, oh, if this patient has a stroke, let's start again with the brainstem. We kind of expect like, oh, they might likely have problems with opening of the upper esophageal sphincter. They might have asymmetry of the pharyngeal wall constriction, etc. So we already have like these like clinical hypotheses. Now we get more evidence that we can also go to other lesion locations, like for example, the basal ganglia, the cerebellum, and can like kind of start to predict what would we expect based on lesion location. Some other like research, for example, with corticobulbar tract, if the corticobulbar tract is affected, we can see a broad range of different impairments. Some of them might also be initiation difficulties. So these are often the patients who present with a late initiation of the pharyngeal swallow. Then, of course, things like basal ganglia or cerebellum, we often observe like coordination difficulties. They might still have the range of motion. They might still can produce those movements, but maybe not at the right time. So again, I think an emphasis is always in dysphagia management. It's not just strength, it's also coordination. And you both mentioned that already.
It's great. It's the third episode in a row where our guest is saying that. I love it.
Yeah. In your paper, you also write about the size of the lesion. How does this play a role?
The first idea is the larger the stroke, the worse, right? And that's typically holds when we look at the overall picture of functional outcomes after stroke. And this makes sense because the larger the stroke, the more areas are involved. So the more functional deficits we can potentially observe. When we think about that, it does make sense. However, this should not be the only answer for us to build our hypotheses who might have dysphagia and about the severity of dysphagia, because patients could have a large stroke, but maybe it affects some of those areas that are not involved in swallowing control compared to a very, very small stroke that might hit just the center of swallowing, right? So for example, one of the central pattern generators in the brainstem, or it might hit the internal capsule, just unfortunately then damages the corticobulbar tract. In one of our studies, we measured the volume of the stroke and then correlated to the severity or to the occurrence of dysphagia, and volume was not a factor. So it didn't really make a difference if you had a small stroke or if you had a large stroke, as long as you consider the site, so the location of the lesion. So there were like 1 or 2 milliliters, so super, super tiny little strokes that were located at the internal capsule that resulted in very severe strokes compared to a stroke of like 100 or 150 milliliter or even larger that were not as severe because they were located in an area of the brain that was not as involved in swallowing. So yes, while volume overall is a factor, it is less important for us to explain who has swallowing difficulties than it is the location of the stroke.
And how does the lesion location in the brain then affect dysphagia recovery? So you've talked about these 50% of patients who recover spontaneously. Is there anything known about their lesion location compared to other ones who don't recover?
Yeah, and to my knowledge, most of that research really has tried to better understand how the corticobulbar tract is involved. So most of that research, I think, that we currently have available is to understand, okay, if the lesion location is located in the corticobulbar tract, how does that then relate to swallow recovery? And typically, if both corticobulbar tracts involved, well, that's not a good prediction. Then some more research also has looked at if the inferior frontal gyrus and in addition, the operculum and the insular. So if both are affected by the stroke, so the operculum, where the primary motor cortex, the premotor cortex is, so where lots of the tracts to the brainstem are located. And if in addition also the insular under the operculum is lesioned, that seems to have an especially poor prognosis. So the idea behind that is that likely the patient does not have reserve or does not have the possibility to compensate for the stroke. So one neuroplastic process is that the residual brain areas might be able to compensate so that those are recruited. But if those very, very important motor areas are affected simultaneously, then there's not much tissue left that could take this compensatory strategy over. So that seems like to be poor prognosis as well. And yes, brainstem, medullar, when it affects the central pattern generators, the ventral and dorsal swallowing group seems to be unfortunately also associated with poor prognosis.
Yeah, thanks so much. It's really interesting, I think. And for everyone who wants to maybe read more about it, we can highly recommend your paper. And there's lots of more literature out there. So we're going to put it in the show notes. In your conclusion section, you wrote, our current knowledge that lesions in many different areas of the brain can be associated with dysphagia falsifies statements such as, this patient cannot have dysphagia because the lesion is only unilateral, or it is too small, or it is not in the brainstem. So does this mean that the location of the brain lesion is irrelevant and does not need to be considered or can even be ignored, quote unquote, when doing a swallowing assessment?
Thank you for this question. And I think what motivated this discussion, this specific paragraph that you said, is that I had this experience as a clinician many, many times that I felt like I had to argue why this specific patient still needs a swallow assessment, still needs to be seen, still needs to get a screening. Because I really had this discussion with other health professionals well, this patient cannot have dysphagia. I think what we still need to probably work on, even though it's implemented in the standard guidelines and I think in most countries around the world, that every stroke patient needs to be screened, at least screened for having dysphagia or not. And so this was how we try to really justify or support this, that there is such a broad neural network involved in swallowing. So every patient is to some degree at risk for dysphagia, not only because of the neuroanatomical correlates, but also because of all these other factors that we talked about. But then moving forward, so yes, every patient should be screened for dysphagia. But then when we do a swallow assessment or an instrumental swallowing evaluation, then I think we can use more of the detailed information that we have about lesion locations to then inform our more detailed hypothesis about swallow physiological impairments, about prognosis, about what treatment might work best. And I think this is where lesion location can help us a lot, but we still need to do a lot of research to really, really be able to use it in a very informed way as clinicians. So I think there is a future of understanding, okay, where's the lesion location? And then, yes, we can make a better prognosis, which patient might not recover as well as another patient. And we can also probably better prescribe treatment to individualize the treatment to more of a personalized rehabilitation approach. But I think we still need to do more and more research and need to better understand how lesions are actually associated with what kind of swallow physiological impairments, with what prognosis and what treatment works best.
So especially for speech and language therapists, you probably wouldn't recommend to ignore it, but to use this information that we have to then really make a comprehensive swallowing assessment and an according treatment plan.
Yes, exactly.
Okay.
So if any speech language pathologist who has access to notes about a CT scan or an MRI scan, I would highly encourage to try to read up on it. There will be a lot of things that might not be very clear, but things about like where was the lesion, right? So, and then you might also, now that you heard about it, more often find, small vessel brain disease. And this will be, I think, in most MRI reports that we read about our patients with strokes, it will be mentioned. And then, of course, the question is then like, how severe is it, right, with this patient? So maybe there are some notes about severe atrophy or there's severe white matter hyperintensities. And then we can take that into account as well, that this might have an impact on the prognosis, or that we might need to be more alerted of like, oh yeah, this patient really needs intense treatment and need to have an extra eye on this patient.
But on the other hand, we don't necessarily need all this information. If we can't access it, if we don't get any information, we still can do our job. Can we?
I think we will always try to do our best job, right? And I think in a dream world, we would have access to way more information than just the MRI. I think the MRI information we have also doesn't give us the full picture, right? I would love to have manometry information. I currently don't have access to manometry for the patients I see in acute care. In outpatient, we do. So I think there's always so much information that we have access to. And with the information that we have, we just try to do our best job. I agree with you.
Thank you so much, Janina. It was so interesting. I think we could continue this conversation for another hour.
Absolutely.
We've reached the end of this episode. Would you mind summarizing the most important points for clinical practice?
I think the most important points are that we should always keep in mind that patients with acute brain injuries are at risk for dysphagia. So no matter where the injury was, they are at risk for dysphagia. So all patients should be screened for dysphagia. Then what we also talked about, that older individuals might be at higher risk because of predisposed factors or because of changes that occur due to aging before the stroke. And I think that we should always take into account that size of the stroke might not be a factor. So very, very small lesions could lead to severe swallowing deficits. And that if possible, if we have information from the lesion locations available, that this could be a valuable asset to our diagnosis, prognosis, and also treatment planning.
Thank you so much, Janina, for taking the time and sharing your valuable expertise. We hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website dysphagiamatters.org. Thanks so much for listening. Thank you, Janina, for coming on the show. Take care, everyone.